Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Colibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Welcome to another episode of our NP Clinical Series. I am Jana Emil. I'll be your host today. And joining me, we have a very special guest, Mr. David Danino. And David, I'm going to let you introduce yourself, but you are a lot of things, right? There's a lot of work that you do. Looking at your bio, Director Emeritus, is that right? You work for counseling services. I think you're an adjunct professor, work with the Red Cross, and tons of stuff. Tell us a little bit about yourself.
Sure. Well, thanks for the introduction. And all of those accolades come with just getting old. So they build up over time. As you said, I was a director of counseling at a university for almost 40 years before I left to go on and do some consulting. I also taught in a graduate school for clinical mental health, and I still do that as an adjunct. So those were the mainstays of my career, if you will. My work with the Red Cross has been as a disaster mental health first responder, and that's in terms of crisis and trauma work. And I've been around the block over the last lot of years. I started doing that work when the Twin Towers went down in New York. I got qualified, certified, and vetted to be on scene to do that kind of work. And I've been at large scale and small scale. I do in Connecticut here where I live. I do the small responses, which are usually fires and smaller storms. But I've done Hurricane Harvey, Katrina. I've been at mass shootings like Sandy Hook, which happened in our home state here, as well as the Las Vegas shootings, doing that mental health work that we have to do right on the scene, essentially. So a number of roles in terms of academic background and in terms of counseling. I don't practice anymore as a therapist, but I teach as a therapist, though. And of course, let's get to the main point here. We're going to talk about suicide today.
Yeah.
I have a lot of experience, obviously, in that area. Working at the college, where the second leading cause of death for college students is caused by suicide. So that's important that we have prevention programs in place and that we have all kinds of feelers out there to get people the assistance and the help that they need. So that's me in a nutshell.
Very good. Very good. So you're not busy at all.
No.
Well, I'm gonna open us up here because you're right. We're gonna talk about suicide prevention and really kind of get down to why we're talking about this, right? And what's the actual data around it, and then really get into the healthcare provider's role. But I wanted to share a story. As I was preparing for this particular podcast, I was thinking about one, I'm super excited that we continue to have these conversations around mental health and mental wellness in our podcast series that we're having. And then I was thinking particularly about this episode today and thinking about suicide in the sense of reflecting, have I been affected, directly by suicide in the sense of was it a friend or family? How has that shown up in my own life? And the one thing that I think about often, and it was interesting because I thought, I don't think I've got, a story in this way, but I actually do. It's one of those things that you realize you don't think about until you think about, and then you realize you think about it all the time. I'm a registered nurse, and in one of my very first roles, this was more than a decade ago, I was working in the pediatric ICU, and I was a very new nurse in there. I want to say it was less than even a year. And one of, a patient I was assigned, we had a new admit that was coming into the ICU. He was a 12-year-old boy, and he was coming in post-suicide attempt. And I still think about that today. And that was more than 10 years ago. And I really think about that today because for me, it was the first real encounter that I had in that way with anybody in suicide attempts or, not. And it was a child. And I remember it felt like this very one-off thing, this like isolated incident that never happens. I would probably never see it again. But obviously we know that's not true. And I've really, thought about that and thought, well, geez, I've carried this with me for a long time because I think about it, really often. And now that I feel like we're all having these conversations more in the healthcare space as it relates to us as providers, as it relates just to the world. You know, this is a really important opportunity, I think, to start to frame up, this really isn't everybody's type of problem, if we will. This is something that everybody should be, aware of and educated in, if you will. So I'm wondering if you can talk to us a little bit about just the basics, on suicide and why really it's a bigger issue than just someone who happens to encounter a patient.
Sure. Sure. Thank you. First of all, thank you for sharing that story
Yeah.
because I think it exemplifies the walk in life that we all have, the journey. And suicide affects us in many different ways. It could be professionally or personally. But I think when we talk about suicide, we talk about degrees of separation, whether you're directly involved in that or more closely involved. And then as those I describe it as the rock into the pond. You have the epicenter where you get the burst of water coming up, but then the concentric circles that move out. That's how suicide affects people. Those closest, then a little bit further out. Best example is when we have a celebrity death by suicide. It affects everybody because they're high profile. Kate Spade, for example, Anthony Bourdain recently, Robin Williams, etc. So it affects everybody. And we all have a story where we at least maybe touched it. So that's why it's an important topic. The other thing you mentioned that's really critical in the last 2.5 years with the nation having its ills and with COVID, impacting us abruptly and changing everyone's life and stress and all those kinds of things that impacted us, we're going to see if suicide rates were affected, or at least contemplation of suicide ideation, or if actual suicides take a bump. My guess is they probably will take a bump because it's been a very difficult 2.5 years. So with that being said, and I know in the healthcare field, for providers, it's critical because your eyes and ears are on patients of all sizes, shapes, ages, et cetera, different populations that you see. And like other professions, it could be a quick pace for profession. And do we skip over this question on an intake or in an annual exam? Or when we're talking to somebody and they say, I am upset or I am depressed, are we asking the suicide question? So today, the hope is to give you an overview of why suicide is everyone's business, including all of those folks in healthcare, whatever role they do play. And then we hope you take the second part of this, which will drill down into a little more information, which we'll talk about at the close. So to get back to your question about the basic concepts, we absolutely want to know the foundation of why we have to be aware of what suicide means and is. And one of the first things I usually discuss when I teach this in graduate school or I'm teaching suicide prevention programs to people who are non-clinically oriented is that people know that suicide is multi-determined. It's usually not one thing, one focused, one item. That means there's lots of input as to why people go on to contemplate suicide or then unfortunately actually die by suicide. And the fact that it's multi-determined, it also means that that we have to have multiple approaches to counteract thoughts of suicides, to get involved in people who might be in the early stages of contemplation by looking at signs, symptoms, signals, and the grand thing when we're looking, regardless of role in life, healthcare professional or personal life, is to ask the question. And we're going to talk about that much more in part 2 of this. How do we go and ask the question and what do we do with the answer? So suicide is contemplated because there's multiple things generally in a person's life that are going on that become very difficult, unable to handle. There might be a mental health issue attached with that. We'll talk about that statistic in a little bit. So if you have those kind of things kind of going in and becoming a burden, let's say that's heavier, much like it has been on all of us for 2.5 years, people contemplate maybe more frequently about what is life? Why do I belong here? Maybe I should not be here. This might be my exit strategy, which we don't want to have happen. So multiple approaches in terms of the person contemplating, and then multiple approaches for the eyes and ears of the community to be on that person and listen and hear what people are saying and ask the right questions. So we also want to remember that most suicidal people really don't want to die. It's just a solution to a problem that can be solved with intervention if they don't isolate and take it alone. So one of the stories I tell about that, you're all familiar with the Golden Gate Bridge. It became really known as a suicide bridge for a period
Yeah.
of time. Yeah, so people would walk and they would get to the top of it and go over the side. Not many survivors in terms of survivors. I don't know, maybe 5 or 6 in the whole lifetime of people jumping. But one person went on to make his living out of doing suicide prevention. And he said what shows in the data when other people have attempted in other ways is that after he left the bridge, he decided he didn't want to die, but it was too late. When that final moment was inside of him and he was falling, he said, I don't want to die. But he went down. They pulled him out unconscious, but he lived, had many issues, had mental health issues in his past. But it can be a very spontaneous decision within a window of several to 24 to 36 hours, where the crescendo, almost like a bell curve, goes up, and then the person's impacted and makes that fatal decision. With intervention before the peak of that happening, we can bring that bell curve back down. Maybe it would involve medication if there's a mental health issue, but it certainly would involve counseling. So we have to access the person so they really can give themselves permission at times to get help. A lot of times people won't do that because it might be a religious issue. It's embarrassing. It's sad. I don't want to bother anybody. But we'll see as we go through this 2-part series. When you ask the question of someone, mostly they're going to be candid in their answer because it's an aha moment that people digest and say, you got me, you know where I'm coming from. So let's talk, let's do something, let's do the next step. But your question to me would be, what is my next step once they say
Absolutely.
yes? And we're going to get to that eventually. And that just kind of encapsulates that most suicidal people want to live, and that they generally are in a position where they can get out of it with help, that we can solve the issues that are going on, but they might have been trying to solve those problems alone. The other thing that kind of ties into this is, I mentioned it with the fellow who jumped off the Golden Gate Bridge, but the ambivalence. Do I want to die? Do I not want to die? And the build up to that. There's a lot of people in my practice over 35 plus years. There's a lot of people who contemplate suicide all the time, not unlike depression, sitting in and living with depression and medicating depression, but the depression never goes away, more dysthymic over time. They're ambivalent and they're going back and forth. Should I, shouldn't I? They're watching the world. They're watching people around them. They're watching what's happening to them. Did another crisis event happen? Did I just get fired from my job? Did I get divorced? Did I have a sudden death in my family? That is probably a factor that would be the last straw on top of the haystack, if you will. So as they're doing that, they're contemplating options to live or not to live. Us as healthcare professionals is certainly at the top of the list, and then us as just the fellow human beings want to be looking, listening, and watching for whatever that is. And later on, if in this 2-part series, we'll talk about those signs that we should be looking for that we might overlook and how we deal with them. One of them, obviously, being when people give stuff away. That's the old adage, like, oh, they give their stereo. I say stereo. You don't give stereos away anymore. They give their music collection away. They gave their iPhone away. They gave their computer away. They gave up on Facebook. They gave up on Instagram after being totally and wholly involved with it forever. So it's the disconnection that we're looking for. Now, as a provider, you're not going to see that every day unless you're in a hospital or you're in an inpatient unit or you're in a center that sees your patients regularly. More than likely, you see your patients when they're ill or they're doing their annual exam in terms of healthcare. So the other thing we need to know, and this is important, and it's important to know that the final decision rests with the individual all the time. And I say that to people because there are times where we can do everything under the sun to get the person treatment, help, inpatient, outpatient, medication, counseling, support, financial support. You can do everything, and a person still will go on to die by suicide. The chances are very, very much mitigated if they have that intervention and they'll go on to live and have a productive, healthy life. But we can't catch everyone all the time because we don't want people to think that they did an intervention, either from healthcare purposes or on the personal side of life, and that they failed at it because they didn't do something right. You're always doing something right. And one of the key features about suicidality is that you can never inject the thought of suicide into somebody that is not contemplating suicide. And that's critical. So, it's just never said, like, are you thinking about suicide? It's somebody would respond like you would respond to me, Jana, by saying, yeah, wow, what a great idea. I'm glad
Right.
you brought that up with me. Doesn't happen. People are either in that realm of thinking about it or they're not. And if they are, and you ask the question, you can get some input back. And then our whole thing is, what do we do with that input? So there's risk factors, a little bit more about basic concepts. There's risk factors that are involved, and we're really going to cover those, I think, in part 2 of this. What do we look for in terms of risk factors? But more than risk factors, what are the protective factors that help people stay alive and not think about suicide and not ideate for a long period of time? So when we look at those protective factors, what can we do as healthcare providers, regardless of what your role is in the healthcare industry, when we're talking to patients and we're talking to clients, whether they're early as kindergarten, young people, right to our gerontologists and working with geriatrics and older folks. And by the way, that suicide rate is quite high for older folks. So you need to know that people in geriatric care, home care, hospices, obviously, there's end of life stuff people contemplate before going to hospice. I don't want to go, so maybe I'll take my own life. A lot of issues for the elderly, for sure. And we'll talk about those populations that are at risk in a moment or two. So that's kind of that's an overview of what I wanted to present at the beginning to kind of set the tempo. And we want to talk a little bit today about the populations, the numbers, and healthcare providers. And then in part 2, we'll get into all those kind of warning signs and what we do. So kinds of questions that might have generated for you, Jana, if you have any.
Yeah, absolutely. That was great framing that up. One of the things that you said, I'm curious, before we kind of talk about the numbers, because I want to hear that, like, what is the prevalence of suicide really? But, you talked about contemplating suicide, and it makes me think of training, right? The training that I've even had as a nurse, just a brand new nurse in the first year. We kind of learn about how we screen for suicide, ideations and things of that nature and what the risk is. But I wonder if you can talk a little bit about, how do we know, and maybe this is part of our, like the provider's role, but, sometimes you feel like this person, they're not really going to do anything, right? Like they're just saying this expression. They're saying, like, I want to kill myself just because it was a really bad week. It was just a crummy week. I don't really think this is a real thing. I shouldn't be concerned about it. Or should I be concerned about it? Do we take everything, do you know what I'm saying? What is that? How do we know? Or is it going to be, hey, if someone says it, if they express it in any way, we must act on it?
Yeah, that is insightful and a great question, because all of the suicide trainings, and what those of you listening now, you might have an organization that goes through routinely some kind of training and mental health first aid, safe talk, QPR. There's lots of trainings out to look at suicide and do that prevention model. They all talk about this in capital letters at the beginning. Take all signs and talk about suicide seriously. Exclamation point, period. So especially, I think, when you're providing services as a mental health provider or as the healthcare provider, you've got to listen to the patient, because we are like bigger gatekeepers of health, right?
Yeah.
So you've got to take all signs seriously. In terms of that being a friend who's lamenting over, like, geez, I lost my job, and then the divorce is going poorly, and
Right.
they have an alcohol issue, and they have weapons in the house, and the kids don't talk to them anymore. That kind of picture has to be kind of placed around the person. And then you have to ask the question, I want to ask you about what you just said about maybe I should just die, or maybe I should just kill myself. Are you having that thought? And here, this is the great thing. If they look at you and they say, what are you thinking about? Like, where did you get that good answer from the person? Because then we can identify that we maybe read into it too much, but you go, phew, I was worried about you, so that makes me feel better. Or perhaps they would say, yeah, I am thinking about it, so what? And then what do you do with the answer, right?
Right.
Friend or as a healthcare provider, But yeah, you have to take all signs and all talk about suicide seriously. So it's important that you do that. Thanks
Okay,
for asking
excellent.
that.
Yeah, excellent, excellent. So let's talk a little bit about those numbers then. What
Well,
is the prevalence of suicide? And I feel like, to your point earlier, you talked about, us just kind of coming out of this pandemic, the world's ills. I mean, you're totally right in that way. So I feel like when we are watching, the news, when we're interacting out in our profession and our spaces, even as our patients are coming through, as we're engaging in different types of continuing education, we're seeing a lot more suicide. The concept and the topic come into our own reality. And so what is those numbers really?
yeah, yeah, and and I think we're going to see a bump in it. But when we do data on that, it's all postmortem, and then it's all done by state Department of Health, and then fed into the federal numbers. And those that are actually identified by dying by suicide, with the identified cause being, self-inflicted, if you will. So the data sets are every 2 to 3 years because that's how data rolls out. So we're looking at 2019, 2020. There's a little data from 2022, but generally speaking, the numbers are that suicide is ranked among the top 10 leading causes of death in the
Wow.
nation overall. You can imagine the other nine are all health related, cancers, et cetera, right?
Yeah.
But suicide has a number. It's a powerful number that is up there. I know that COVID just bumped to number 3 in that list of 1 to 10 of the cause of death. So that's a big number right now. Hopefully that'll dissipate quickly. So the 10th cause of leading cause of death, and in 2019, 2020, there were about 1.5 million people that died by suicide. So that's a big number. And for those of you that deal with kids, it's the second leading cause for youth and young adults aged 10 to 34. So kids, and I've heard these stories. I don't deal with a lot of children. I didn't deal with a lot of children in my career, but there's young children as early as 6, 7, 8, 9 that have died by suicide and contemplate it and have access to look at the internet and figure out how to do that. And a lot of that is done by pill taking or, unfortunately, sometimes hanging. It's very sad. Almost 37% of the people in the last survey, so we're getting up there to about a third of the people were 55 and older to make that determination. And it's also important to know inside of those numbers that what's reported back to DPH by the coroner's office postmortem is that 90% had a diagnosable mental health condition at the time of their death of some kind. That doesn't mean that they were schizophrenic, bipolar, or off on the very heavy end of having mental health issues. That could be, as I talked before, about a depression, dystemic part of their life that they carry with them. But something that was diagnosed. And I'll talk about the numbers in a minute that have seen actually medical professionals prior to their death, either the year before or some point in time prior to their death taking place by suicide. So 45,000 deaths, give or take, and what the methodology is, and you could probably just easily guess at this. Firearms are number one. Access to firearms. That's when I spoke before. If a person's having a bad time and they turn to alcohol and they have firearms, that's kind of a very lethal triangle where we have to look at, like, will a person act on what they might want to do? And we know anytime you have a substance abuse issue, it clouds judgment, right? That's the worst part, because then you're doing things impulsively, and something can happen that could be tragic. So firearms. The second is suffocation. And there's poisoning. And others. So that access to weapons in our society, unfortunately, is the root of lots of things that happen. So access is an issue there. So it's big numbers. I think that, I can kind of roll that over probably into the next topic, which is the populations that are at risk. So I said before, adults over 45, that's a very large group. That's a large number of people that die by suicide. So we want to keep that point in mind. Then we have And this is in no specific order, but these are higher risk groups, if you will. Certainly, we're concerned about veterans. You read about that regularly. A lot of you might work for the VA or agencies that work with veterans. So we want to be concerned about our veterans, I know that they have rolled out a terrific, robust suicide prevention program inside of the military. I've been part of those trainings here in Connecticut with the National Guard, and how they look out and they teach other reservists and other military people to look out for their folks that they work with. So older adults, veterans, a myriad of racial and ethnic groups. You could list those down. American Indians, for those of you that work out where there are larger populations, or Alaskan, Native Alaskans, African American, Black population, Hispanic, Latino, and then we also have Asian and Pacific Islanders. So these are pockets, but if you look at the pockets, each is its own constituent area, and each of those areas gets larger and larger as you build out. So you want to describe, and we'll do this a little bit in part two, what's at risk and why is that risk higher? So what I just mentioned to you, and I want to include here most specifically, because your antennas should go up when you're talking to persons of color, veterans, those racial and ethnic groups I talked about. But I can't be remiss and not mention the LGBTQ plus population.
Absolutely.
There is very large risk. And inside of that, the transgender healthcare part of it for anybody that is dealing with the LGBTQ population is incredibly high. The risk factor doubles and triples. So that's important that we know that with a person that we're providing health services to, either mental health services or physical healthcare services, that the risk is higher. And we have an obligation to know that in the field we're in. Generally, as a person, you should know that it's just higher than heterosexuals experience. So that's really critical that we look at that for the populations. Let's talk a little bit because we wanted to talk a little bit. Any questions about that popped into your head, or we can move on to healthcare provider role?
Yeah, what popped into my head as I'm thinking about this is, and we'll talk a little bit about this, I think, in part two, of our podcast, but thinking about the question, right? You mentioned that things like a history of mental illness, for instance, certainly could factor into this, but I'm wondering a history of familial suicide attempts, if that factors into that. And I wondered if we even ask that question as part of like our role as a healthcare provider, is that one of the history questions that we ask? Should we? Is that something that we should ask if there is a risk?
Yes and yes. Yeah. I mean, yeah, absolutely. I mean, because if a family has a history of suicide, you're going to see generally there might be an issue with mental health that might be an undercurrent. And we know that can be hereditary in terms of depression and other kinds of things that kind of, leak into our lives. So yeah, it is a question to ask. People who have been impacted directly by familial history, it's important to ask that question. And these are, in healthcare, we ask a lot of hard questions all the time about a lot of different topics, and some of them are embarrassing for people, right? This shouldn't be embarrassing. It should be one of those checkoff things like, have you thought about suicide in the past? Are you currently thinking about suicide? Did anybody in your family die by suicide? How recently did they die by suicide? Those kinds of things, because it's part of the package of assessment, right? So yes and yes to your question.
All right. Awesome. Thank you for that. So yeah, talk to us a little bit about the healthcare provider's role here.
Yeah, and this is, and I think we were going to end with this and a couple of final comments, but it's important because, in addressing healthcare providers, anybody who has a license that is working with patients from LPN up to whatever you want to be. If you have patient care and patient contact, you have a responsibility. And you all know our level of responsibility is higher than the general population, just by our training. And certainly we're ethically and legally obligated to do that. But here's some telling statistics I would just put forward, and that is that after I talk about the provider role, I'll give you some data on that. So we're in a unique position as a provider. We get to see patients and clients in front of us, maybe not so frequently. That's why we have to be thorough in our assessment of what we're asking and what we're doing. But I mentioned before that there's some data that was recovered by some researchers that said around 45% of people who had contact with their primary care provider, about 45% of suicides had contact with that provider within a month. So that's closely aligned for that person taking their life. And then when they do that postmortem, they see that they had a healthcare visit somewhere. It could have been for a cold, it could have been an annual physical, it could have been anything. It could mean nothing, it could mean something. It depends on how the patient presented, and then what questions you asked to find out about what happened to that, what was going on in that person's life. The number's higher when you roll it back a year. It could be up to 3/4. 77% of people saw somebody in a primary care position before their death. Now, when you drill down to the data that could have been an annual checkup, right? So it could be half meaningless, but it might not be meaningless. I think the point I take away from that is that if they see us, we want to be asking the questions, as you do about mental health issues or sexual health issues. You want to ask the questions in the same way. They're not threatening, they're not judgmental. They're just open-ended questions so that you can get a read on what your patient, either inpatient, outpatient, or whatever that person is seeing you for healthcare purposes. So we see people who have mental health issues. We know that it could be low level, it could be high level, and that's depends on your role and what your treatment is with them. But we want to check for that risk of suicide in our role. I said at the beginning, we're larger, bigger gatekeepers than an average person encountering someone. We know that. We carry that with us as part of the role that we provide. So what we're trying to do here is to provide some education on suicide-specific skills, understanding ideation, understanding suicide death, and then looking at risk factors and how do we make a determination of everything we're looking at to judge how low is this level or how high is this level? And ultimately, especially for mental health clinicians, do I let the person walk out the door at this point or not? And that's the ultimate decision is if you're going to hospitalize, which is a very serious thing for the patient and for you to do, but appropriate if necessary for sure. So we are already seeing people. We should be in a position to do some work with that. The last thing that I'll say, and then we can have some final comments, maybe if we're at about that point. The part I want to reiterate this: the part about 90% of the people having a diagnosable mental health disorder at the time of their death. The sub bullet point there is that again they come into contact with some kind of a health professional during the time of their suicide risk. Did we know that? Did we ask about it? Did they tell us about it? Do people also, and we know this in mental health as well as healthcare services, we know that people can be pretty good at playing their life out in front of us, and they're not always honest, but they appear to be honest. And it's not unlike other things where people have substance abuse problems and they try to hide the fact that they have that problem. They get really good at it, and that's why we get extra training to understand, to hopefully understand and penetrate that show that is like everything's really good, but we know it's not. So how do we tear down or peel back the layers of that so we can get some help for the person? So that becomes the important thing. So follow-up question and maybe some closing things.
Yeah, that was excellent. Actually, this has been very, very insightful. And I'm really looking forward to diving into some of these concepts here in part two, really getting into those warning signs and things we can do about it and the risk factors.
Good. I'm glad to hear that. And I hope people watch it. And it's not something we deal with all the time. Not every person that's watching this, they may not never even entertain the suicide question based on their role, but you should be aware of it. You should be able to manage it. You should be able to recognize it. That's critical. And then, as John has said, then we will talk about in the next chapter, the next 30 minutes, what suicide talk is, what the behavior is, risk factors. And then the key part of that, the last 10 minutes of that will be, what do I do for an intervention?
Exactly.
So Jana asked me the question, Dave, are you thinking about suicide? And I say, yes, I have thought about it. What's your next question? Usually people freeze and go, I didn't want that answer because now I have to deal with the answer and I have to have an intervention. Now, as healthcare providers, we should be ready to do that. If you're a lay person, you got to have some skill set to say, okay, what's my next step with this person who just told me they're contemplating and they want to die by suicide? So
yeah, looking forward to exploring that with you, David. Thank you so much. I appreciate you for joining me today for this dialogue. This has been great.
Great. Hopefully see everyone in part 2.
Absolutely. And thank you all for tuning in to our podcast. We absolutely hope you'll join us for part 2 of this conversation. I am Jana Emil, and on behalf of myself and David, thank you so much for joining us. Goodbye for now.
This podcast featured content from an accredited CE activity provided by Colibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.